Thank you very much. So evolving concepts, and this is certainly an area where the evidence is now pouring in. And in fact, at the end of my talk, I'll give you the results of a new randomized trial presented yesterday at the Heart Rhythm Society that's absolutely bang in this area about AF and heart failure. So I'll keep that right to the end, and you just have to pay attention to my last slide. But lots of interesting things going on in this space. And you know the issue in your clinic. Somebody gets referred, is this heart failure, is it not? You feel their pulse and it's atrial fibrillation and your heart sinks. Because you know that there's so many more issues that you're going to have to deal with. Do you have the time? What are you going to prioritize? How can you explain this to the patient? So it does make it much more complicated in clinical practice, but it's a huge area of unmet need in terms of symptom control and actually changing the natural history of the condition. So interesting medicine, but challenging medicine. Now, we do know that the sicker the patient, the more severe the symptoms, the worse the ventricle, the more likely that atrial fibrillation will complicate that situation. So these are old data now, but you can see as you go from NYHA 1 through to 4, the prevalence of atrial fibrillation steeply increases. So a lot of hospital practice with advanced heart failure is in the atrial fibrillation space. Now, the question is, of course, is whether the AF is just a bystander, whether it speeds up the deterioration, whether things that target the AF might change the heart failure outcomes, all of those issues as you go along that spectrum of severity. It's also true that if your patient doesn't have atrial fibrillation currently, that there is a risk of that developing as time goes on. So these are data from Framingham, and you can see there's about probably a 5 to 10% chance each year that atrial fibrillation will develop. And now that we have many patients with implanted devices, we know that many of them flirt with atrial fibrillation, with very short bursts of it from time to time. So it's a complicated scenario, and a lot of the guidelines really oversimplify the difficulty in clinical practice, and I'll come back to that. But the question is, atrial fibrillation, heart failure, are they the same, are they different? Well, here's an example. 75-year-old man, long history of hypertension, pretty well controlled, and also type 2 diabetes, comes to the clinic, breathless, tired, but aren't we all, and unable to walk as quickly as before. BNP is raised. If they're in sinus rhythm, what are you going to diagnose? Well, he's got raised BNP, he's got symptoms, probably got some fluid retention, he's got the right history. This is heart failure. Yep, most likely. You're allowed to nod your heads. Yes, this is most likely heart failure. What if they come in with atrial fibrillation? You might say, well, maybe it's not heart failure. Maybe it's just symptomatic AF, breathless, AF, raised BNP. Okay, let's call this atrial fibrillation. It's the same patient. So it depends who you send the patient to as to how they contextualize the problem and probably what they will target. So it is complicated, and I think a lot of the times we just look through the issue with our own particular prism. Now, here's a question for you, which means that you need to give me an answer. This paper was published in this year that actually gives us some data on this. What year was this? Google was created, the International Space Station was launched, and I believe that is one of Mr. Clinton's close associates. Which year? I've got 99, 98, and luckily the chair is correct. 1998 this was. So here's the key paper from 1998. And this is looking at the solved database, looking at the association between atrial fibrillation and LV systolic dysfunction. Does it actually, how does it play out? And so this is what it shows. So there's a clear association. If you have LV systolic dysfunction and atrial fibrillation, you're on a worse trajectory than if you're in sinus rhythm, and it's quantified there. It's similarly also for heart failure hospitalization and progressive pump failure death. So very clearly, AF is at least a risk marker for your patient. So high-risk patient, you need to try and redouble your efforts to try and get control of the syndrome and long-term. But it's maybe just a risk marker. We can't really say on the basis of that that it's a risk factor. If you kind of then put it in the constellation of all the things we know that impact the natural history, this is the multivariable analysis. So obviously the older you are, the worse you're going to do in general. Atrial fibrillation, 40% increase in pump failure death over the follow-up period. And we've got ejection fraction and severity of symptoms, diabetes. But atrial fibrillation is certainly one of those very important factors in terms of being associated with a worse outcome. Now, one of the areas where we do have very good evidence is the association between atrial fibrillation and thromboembolism. And if you have heart failure, then certainly the risk of thromboembolism is substantially increased. So the default position probably should be heart failure plus AF requires anticoagulation, unless you've got a very good reason not to. And you see the pictures there that we should be trying to prevent this. And if you go to the guidelines, so this is the ESC guidelines for heart failure, and you look at the arrhythmia section, really the only high quality level Class 1, level A evidence is not about AF management at all. It's about anticoagulation to prevent the risk of thromboembolism. So huge evidence-based therapeutic imperative, but it's not really about treating the AF. It's about reducing the risk of major stroke related to left atrial thrombus. So that's the 1A. Most of the other evidence is actually pretty weak, and I'll go through some of it in a second. But there's some good news, don't worry, that if you actually treat heart failure well, particularly systolic dysfunction heart failure, you can at least delay the onset of atrial fibrillation. So this is really important. So here's the evidence for ACE inhibitors, particularly strong, less for ARBs, but certainly there. In this meta-analysis at least, there's almost a 40% risk reduction for AF. So another reason to get control of the heart failure syndrome, to use RAS inhibition, because you will reduce the risk of AF and subsequent risk of thromboembolism, and also probably improve the outcome. It's true also for aldosterone antagonism, at least for eplerenone, but presumably also for spironolactone. And you can see here data from Emphasis. So this is NYHA2 heart failure, usually on background ACE inhibitor and beta blockade. But you see even on top of that, if you also have the MRA in there, you can reduce the risk of atrial fibrillation developing. So I think very important and under-recognized and not really emphasized in the guidelines enough. These are other reasons to go for triple therapy in a patient with LV systolic dysfunction. Now, there's one thing which doesn't quite all line up, and that's ivabradine. So we know that if you get heart rate control with ivabradine, you'll drop the heart rate, obviously, and that translates into reduction in hospitalization, quite dramatic reduction, first, second, and third hospitalization. And for those with a faster heart rate, pretty convincing evidence of mortality benefit. But what you also get with ivabradine, because it's such a powerful heart rate agent, is that with the more bradycardia, you get atrial fibrillation triggered. It's not a direct toxic effect, okay? At the normal plasma levels, no effect on atrial fibrillation origin itself directly. It's more about the bradycardia and getting the breakthrough. I've looked at this in quite a lot of detail and written editorials about this, and we had to go to the European Medicines Agency with the data. And it's true there is a slight increase in atrial fibrillation. So if your patient has lots of paroxysms of AF, I wouldn't go for heart rate control with ivabradine. But on average, a sinus rhythm patient will do much better with lower heart rate with ivabradine than not. And in fact, the stroke rate in the SHIFT study was lower in patients given ivabradine. So yes, there is a small increased risk of atrial fibrillation episodes, but they're probably not that clinically important, and certainly the patient still benefits from heart failure endpoints. But just to make sure you're aware of the evidence base for these different therapies. What about the fact, can we go beyond the fact it's just a risk marker in these patients? So yes, okay, we've picked it up. We know the patient's going to do worse than they would have done in sinus rhythm, but do we actually have to go in and try and get them back to sinus rhythm? What's the advantage of that? And of course, things have swung over the last 20 years about very aggressive attempts to do it. We've got now a range of options, not just drug therapy, but also ablation therapy. So the second half of my talk is all about where this evidence-based has moved. Should we be trying to get sinus rhythm back, and if so, in which patients? So I think this is a Canadian-led study, so you should all know this much better than I do. This is one of the first large studies in this, and this is looking at heart failure and trying whether rate control or rhythm control might be better. And at this point in time, when the study was going on, a lot of centres were setting up very aggressive DC cardioversion plus or minus amiodarone programs and trying very hard to keep people in sinus rhythm. So here the heart rate control was quite aggressive, resting heart rate less than 80 and less than 110 on walking. And if you didn't achieve that, then you would nodally ablate and put in a pacemaker. And then the rhythm control was drugs like amiodarone, but also sotalol and dofetilide and repeat cardioversion. So certainly quite an aggressive rate and rhythm control strategy, and no difference in the primary endpoint there in outcome. Patients seem to do very similarly with both strategies. And in fact, all of the secondary outcomes were neutral. And a lot of discussion about maybe it was too aggressive, maybe it's just that the drugs we used were very toxic drugs, and that's why we couldn't pick up the difference. But certainly published 2008, so 10 years ago now, but took the heat out of these big programs of DC cardioversion and amiodarone that many of us had set up. The evidence from the patient benefit, quite hard to find in this study. Well then, of course, there's the magic dawn of ablation. And of course radiofrequency, but now with cryoballoon, I believe it is now so easy that even the cleaner in the intensive care unit can now do atrial fibrillation ablation. Thank you for laughing, that was a joke. But certainly it's now faster procedures, probably more effective procedures, so opening up potentially more patients to this if you select the right patient. So you get the idea, you go in there, you change the substrate, you get rid of the atrial fibrillation and hopefully it stays away. If it doesn't, you can repeat the procedure, and ultimately maybe 50 or 70% of patients will be in sinus rhythm for at least a few years. And of course a lot of expenditure, cardiologists like doing things, and globally, huge investment in this area. But of course, the number of patients with AF is enormous. How do you target which ones are going to do best? And how do you appropriately counsel patients as to whether they really should go through this or not? And what's the size of benefit and the likelihood of that? Big questions. Now, there's certainly a lot of published literature to suggest that getting back to sinus rhythm seems to make the heart happier. I use a very unscientific term. I always have concerns about these meta-analyses. It's very difficult to publish neutral or negative small studies, and much easier to publish positive small studies. I know that as an editor and also as a trialist. But here at least, if you look at the studies, a suggestion that yes, you can get the majority of your patients back into sinus rhythm, medium term. And if you do that, then there does seem to be quite a substantial improvement in the left ventricular ejection fraction. So there's certainly a biological rationale, rhythm and mechanical function going hand in hand. So quite a lot of data now. That was just published in 2015. What do the guidelines say? This was published in 2016, the European Society of Cardiology guidelines. They're being updated at the moment. But you can see here we've gone away from this level 1A evidence about anticoagulation to prevent thrombus. We're going down to level 2BB. And the key phrase that keeps being used here is may be considered. In other words, you can do what you like, because we're not sure what the right answer is. But certainly, both DC cardioversion and ablation may be considered for patients with symptoms and atrial fibrillation. And that, of course, is very permissive. It means that whatever you believe, you can do, but there's huge inconsistency across countries, across centres, between physicians as to what they're actually doing. So the evidence base needed to be tightened up. So here's the two new randomized trials for your delectation. First one is Castle AF, just presented a few months ago and published simultaneously in the New England Journal on February the 1st. And this study had run for a very long time recruiting patients, but these were heart failure patients, and they were put forward for catheter ablation or medical therapy. So I think let's really focus on the type of patient here. This is really important. So they were symptomatic. They could be persistent, most of them were, or paroxysmal. They had to try drug therapy but have either unacceptable side effects or still quite problematic symptoms. They were all quite severe systolic impairment, so you'd recognize these patients. Ejection fraction 35% or below, and all of them had an ICD to protect them from sudden death risk or reduce that risk. Now, this study took 8 years at 33 centers to randomize just under 400 patients. So that tells you something very important. It means that the characteristics of the patients are quite peculiar, and that even at these busy centers, they were not really putting many patients into the study. Maybe they weren't in equipoise. Maybe they had preconceived ideas about who might benefit. But if it takes you that long with so many patients to identify so few, that certainly challenges the external generalizability of the study. But leaving that to one side, a lot of effort by a lot of people to do this, and the first medium-sized study. Followed the patients for quite some time, but of course they could do that because it took so long to recruit. The study was running forever. And you can see the characteristics of the patients. Average age 64, so young for heart failure. Mostly male, only 15% women. Most of them very mild symptoms and quite small atria. The average was 48 and the IQR 45 to 54. So youngish, mildly symptomatic, well treated, not terribly large left atria patients went into the study. And what they found was almost unbelievable benefit in terms of the endpoint. So the first one is death or hospitalization for worsening heart failure. You can see these curves separating and continuing to separate. It's testing my visual acuity, but the p-value looks pretty good. I can see a few zeros before a digit. Death from any cause, also significant. So all-cause mortality, difficult endpoint. But remember, this is a small study, but even that was positive. And hospitalization for heart failure, consistently less in those that were ablated. Then, of course, we all love subgroup analysis. We say, oh, well, okay, that's a bit of a surprise. That's pretty impressive. But tell us who really got the benefit, or whether groups that didn't get the benefit. And I've just picked out of interest. In fact, you can see it is actually the milder patients, so NYHA2, so milder symptomatic level, and definitely those with the higher end of the severe impairment of the systolic function. So this is not the very symptomatic, very dilated, very poor functioning ventricles with huge atria. This is milder disease, smaller atria, younger people. Maybe there is evidence here that they might benefit from an ablation strategy. Interesting, diabetic patients didn't seem to have any benefit at all. It's a non-diabetics. Does that relate to fibrosis? Does it relate to the metabolic state of the myocardium? We don't know. It's all just hypothesis generating. But very interesting. I was actually at the presentation, and afterwards, over a beer in the evening, I asked a range of colleagues, heart failure and EP, what they made of it. And all of them went, not sure. I think I'll just keep doing what I was doing before. So difficult to know, and I think there's a lot of question about the size of the study and the type of patients, but if you believe in ablation for younger patients with less damaged hearts, this would confirm that belief. All right, now, this is the real money shot from this. This is a study that was presented yesterday at HRS. So this is Cabana study, very much larger, 2,200 patients with quite decent follow-up. A really impressive study, the largest in EP actually, in terms of ablation ever, so really important. Now, I haven't been able to get hold of any paper for this, so I have just downloaded what was put on the internet. So the result was primary endpoint neutral. Say that again, primary endpoint neutral. No difference in overall cardiovascular mortality and heart failure, hospitalization, and a few other components. In fact, all of the components of the primary endpoint were neutral. On intention to treat, So if you believe in intention to treat, if this was a drug, it wouldn't get a license. However, and confusingly, if you look at the actual treatment given analysis, so you only look at those that were ablated, and you adjust for the crossover, which was quite substantial in the trial, it's positive. So it's great. Large study, overall neutral, but if you had an ablation, you did better. So in other words, most of the Twitterati comments on this are, isn't this great? We can just keep doing what we were doing before. So it just confirms your prejudice. So it's late in the afternoon and I'm jet lagged, so I'm slightly more cynical than normal about this. But I don't think this is really going to change people's practice. If they believed in ablation before, they will use the analysis to support that. If they didn't believe in ablation, they will also use the analysis to support that. So sadly, I'm not sure how changing this will be, and it'll be interesting to see once all of the data is available and we go through the tea leaves of all of that and what the guideline writers make of it. I didn't have time to look at the share price of the companies behind this, but that will also give you some idea what at least these investors make of the study. So, Mr. Chairman, ladies and gentlemen, where are we at the moment? So the first slide is text, which you can read, and the second slide, I think, is just a visual impression of all of this text, which you'll probably remember for a bit longer. Obviously, the two conditions overlap a lot. It's hugely important to pick up the AF, not least because of the thromboembolic risk that requires anticoagulation. The symptom control, at the moment, it's still not clear how aggressive we should be about heart rate or rhythm control. We have got 2 recent randomized trials, a lot more data, but I'm not sure if it gives us a very clear answer. My own prejudice is for my younger patients without huge structural issues that they certainly should be given a chance. And if they're willing to accept the chance that it may not make a huge difference, but it might, then they do go for ablation. And many of them do get back into sinus rhythm, and many of them seem to be symptomatically better. But of course, there's nothing like the lack of a control to exaggerate the effect of your intervention. But that's my own practice at the moment. I do put forward for ablation a particular subgroup of heart failure patients relatively early on in the process. But I think we do need to be honest with our patients about how strong the evidence is, what's driving this, so that they can come to a shared decision about what the most appropriate therapy would be. You're probably not going to remember all of those bullet points for very long, but you will probably remember the next slide, which is my view of the current guidance for AF and heart failure. Thank you very much indeed.